Welcome to the Gastro Girl Podcast. We bring together patients, experts, and health advocates who are all here to help you optimize your health. Here's your host, Jacqueline Gaulin.
Hi, everyone. Welcome back to the Gastro Girl Podcast. I'm Jacqueline Gaulin, and today we're talking about something that can be a bit overwhelming and confusing for parents and caregivers of children. When your child has trouble eating, gaining weight, or simply enjoying meals without discomfort, these can be early signs of a chronic condition called eosinophilic esophagitis, or EoE. And while it's often misunderstood, today we're bringing you clarity and compassion straight from one of the leading voices in pediatric GI care. Joining me today is Dr. Joshua Wechsler, a pediatric gastroenterologist at Northwestern University. He specializes in treating EoE and other allergic GI disorders, and he's here to walk us through everything families need to know, from symptoms to diagnosis and treatment options. This episode is brought to you by Sanofi and Regeneron. Thank you for joining us, Dr. Wechsler. It's so great to have you on the show today.
Really appreciate the opportunity to be here.
All right, let's just jump right in. We've done a lot of episodes on EoE, and we interviewed a parent and her son who's getting ready to go off to college, and it really gave us a good insight on their journey from the patient side and what they went through. But it also raised some questions that our listeners may have, which include, what are the earliest signs of EoE that parents or caregivers should be aware of for infants and children?
Yeah, so I think that's a great question. And for EoE, it really comes in a couple of flavors. So there's the kid that has frequent vomiting. Sometimes they might have heartburn, so they may just say that their chest hurts. Especially for young children, that can be very difficult to really say it's heartburn. So that frequent vomiter, that's definitely a warning sign, especially when it's chronic. May not be even every day. Maybe that it only occurs a few times a week. That's going to be something that's going to need a workup. Anytime you see poor weight gain is definitely a red flag, pretty much in all of pediatrics, but especially poor weight gain usually indicates you're really not getting enough calories in. That's going to be a reason to think that EoE may be one of the reasons to explain what's going on. Then a whole host of really what are ultimately behavioral adaptations to the discomfort associated with food going down. So this can be anywhere from typical picky eating, refusal to try new foods, aversions to previously established foods, so chewier foods, drier foods, so drier foods being things like breads, rice, chewer foods, of course, being things like meats, very prolonged meal times, excessive chewing, requiring the food to be cut into really small pieces, sometimes pocketing the food in the mouth, so it just kind of slows down the swallowing process. Spitting the food out. This is, of course, again, something you see in just typical picky kids. These are really common things that you might see. Of course, if there's choking and gagging, this is very objective. This can be very obvious. This is going to be something that's going to come up. So could either be a symptom that's very objective, or it could be something that's more subtle, really oftentimes requires some questions, and you might mistake it for something that's behavioral or allergies or something like that, but really need to be thinking about EoE as a possibility.
So what role, if any, does development stage play in how EoE symptoms show up?
Great question. So depending on the age of the kid, really, the symptoms do vary quite a bit. So young kids tend to have more of the vomiting, poor weight gain. As the kids get older, tends to be more of the chest discomfort, heartburn, really can still have some of the vomiting, but you don't see quite as much of the poor weight gain and the feeding aversion now. As the kids get quite a bit older, now into the teen years, you tend to see more that I feel like food goes down slowly or food gets stuck. But really, one thing I learned early on is you just have to just assume that any symptom is reasonable for any kid. So I'm asking everybody I see about all potential symptoms. And really, in some cases, until you've been asked about it, you may not even realize this is not normal. And again, most of these things that we're talking about, they're very clear evidence that there's a problem, especially when food's going down abnormally. And for a lot of young kids, it can be very hard to verbalize what they're feeling. These avoidance behaviors, the distress during meals, just is such a challenge for them. They don't really know what's going on. For older kids, again, like I said, they may have that feeling like food gets stuck. They may just drink a lot of water or maybe they just start avoiding certain foods and then it's not such a big deal. But really, when you ask about it, you find that there's a problem. And for anybody, when there's food going down slowly or getting stuck, that's just not normal.
Yeah, let's go back to the food getting stuck. I mentioned we interviewed a young man who was getting ready to go off to college, and he was sharing his journey to EoE diagnosis. And he constantly said how food would get stuck, and he normalized that even throughout his school years, where, oh, it's just part of when I eat, this is what happens. And really, I want you to really explain to our listeners why that's not okay.
Yeah, great question. So the reason that food typically gets stuck in EoE is related to the complication of EoE. So as EoE continues for quite some time, the esophagus will narrow. It will either narrow in a very specific spot or even along a very long segment. And of course, that just makes it very hard for food to go through. And even sometimes the way the esophagus squeezes might be off too. Both of those things can contribute to the feeling of food getting stuck. And a lot of patients will figure out, oh, if I just don't eat this food, or if I just drink a little extra water, or if I just sauce it up a little bit more, cut it kind of small, I'm okay. I can get by. And because it's kind of subtle, and they may be able to adjust to it, and they just want to keep up with their friends, or they just want to enjoy meals with their family, they're able to sort of push it aside. And it's not until it keeps getting worse and worse, and as that inflammation goes on, the esophagus narrows more, even more foods now get stuck. Then there's the point at which you say, this is really a problem. And we're very hopeful that that can be diagnosed earlier and earlier. Because again, that idea that food's going down slowly, getting stuck, it's just never normal.
So speaking of diagnosis, what happens next? If a parent, brings their child to you, and when do you know to make the recommendation, and what tests? How do you decide how to diagnose EoE?
For better or for worse, endoscopy is really the be all end all. It is the gold standard for diagnosis, and it is ultimately required. We can't use a blood test, and there's really not a minimally or non-invasive test that's really ultimately ideal for making the diagnosis of EoE, where you can not just assess how spread out the disease is. You can ensure that you're getting good biopsies of multiple areas, but you can also make an assessment of, is there a complication? And you can also assess, is there also a problem in the stomach and the small intestine? And some EoE patients will also present with inflammation in their stomach and small intestine. This is going to need to be found as well. Now, when we do a scope, in children, this requires general anesthesia. So your child's going to be under anesthesia. In most cases, this is either with an inhaled gas or with the drug propofol. With an experienced anesthesiologist, this is going to be a very safe process. It's typically going to take something like 10 or 15 minutes. If there's a complication where there's a narrowing, we need to stretch it out, that might take a little bit longer. But the good news is that the risk for all of this is very, very, very low. So I talk to patients about how safe endoscopy is, how safe the anesthesia is. Of course, an anesthesiologist will be talking with them about that more. But this is really valuable for making the diagnosis, and ultimately will be absolutely necessary for surveillance, for understanding whether the treatment's working or whether complications have developed.
Now, once you do the endoscopy, how long does it take for you to have the diagnosis?
Great question. So I think in most cases, when we see abnormalities, we're pretty confident we know that it's the diagnosis, but it really requires that review of the biopsies of the esophagus to ensure that there's the correct number of eosinophils, that you're above a certain threshold, that this identifies EoE ultimately. And that's dependent on your pathology department and how quick the turnover there is. I've seen results come back in 2 days. I've seen them take a week. But somewhere in that range is typically the norm. And once you get those results back, it then comes down to the healthcare provider communicating with the family, what's going on, trying to explain what's going on. And I think in all cases, a visit back in clinic's vital to really talk about what does this ultimately mean.
Yeah. So if I'm a parent and I get called back into your office, the first thing I'm going to ask you is, what causes this before we even go into the treatment? And how do I decide what treatment option is right for my child?
The short answer is it's complicated. There's both genetic issues as well as environmental. It gets even more complicated if you dive into the genetics and the environmental factors, because we really don't understand exactly on a patient to patient basis what actually caused their EoE. And I think many patients, of course, want to know that, but at the end of the day, what we can say is that in almost all cases, food proteins are playing an enormous role. So we know from patients that have gone on diets that lack food proteins that almost all of them get better, and that we can subsequently reintroduce specific foods and identify the triggers of EoE. And for some patients, it's one trigger, and for other patients, it can be a few triggers. That being said, understanding really sort of causality gets a little tricky because we can't really tease out much more than that. But we can at least begin to understand, hopefully, maybe what are the causative foods for some patients at least.
So in an infant, would you start with eliminating milk per se or something like that?
Yeah, I think for young children in particular, diet therapy is very good. So the parent has a lot of control over the diet. The kid's very dependent on what mom or dad is preparing in terms of the foods that they're eating. So I think for young children, particularly children that don't have severe food allergies, where they already have a lot of restrictions, or potentially they don't have very severe feeding aversion, where taking away more foods may actually fuel that aversion, this can be a very beneficial form of therapy. As you mentioned, milk is really a key food, and in probably something like 80+% of patients, it is a trigger of their EoE. Probably in about 40+% of patients, it's the only trigger of their EoE.
Wow.
So we do think that one food elimination diet, removing all dairy, and again, this needs to be an exclusive removal. You have to get rid of all the dairy in the diet. A dietitian will be vital for helping you understand what are the replacements, where's the cross-contamination, what potential nutrients like calcium and vitamin D might you be lacking where we need to supplement. Is there potentially even formula that's beneficial? That's all going to be something that we're going to consider for a young child for sure, in addition to talking about all the other therapies.
No, that's really a great point, because working with a dietitian, especially with children, you want to make sure that they're getting enough nutrients so that they can thrive and grow properly, because that was the problem before, right? They weren't getting that nutrition and they were struggling to thrive. Now, with that said, what are the options for treatment in terms of, I know in the last several years, we've had huge strides in what's available for EoE patients, especially for kids. There's been a lot of approvals for really great treatment options. And what are they, and how do you explain those to a parent to make the right decision for their child?
Yeah, that's a phenomenal question, because I think it's really important that when we're discussing the therapies that we need to have shared decision making, but physicians and healthcare providers really need to be aware of what are the bevy of options. And really, it's very helpful if you understand to some degree how well do they work, and then what are the benefits and the risks, because I think all of this needs to be considered. So swallow steroids have been a mainstay treatment for EoE for quite some time. Essentially, you're taking topical steroid medicine, a medicine that's been used for asthma, been used for eczema, and you're swallowing it, you're letting it coat the esophagus, help control that inflammation, reduce it so that that inflammation is gone, and ultimately prevent a complication. These medicines typically come as oral viscous solutions or as inhalers. Typically, they're given twice a day with nothing to eat or drink for 20 or 30 minutes. And in some cases, if they're working well, can be reduced down to once a day if you demonstrate with that twice a day therapy that it's effective. Proton pump inhibitors, these are commonly over the counter. These are medicines that are classically thought of as acid suppressors, but for EoE, they may be working through other means. Again, typically will be given twice a day. And again, need to be reassessed with an endoscopy as well. There's a whole assortment of proton pump inhibitors, and they're by and large very, very safe. There's a lot of studies looking at many, many years of treatment of acid suppression, and really not much risk there as far as those drugs are concerned. And then elimination diets, empiric elimination diets, most commonly where you're taking away the most common foods of EoE. We do not use allergy-based testing for elimination diets, so skin prick patch, blood testing, this is not considered effective. If your doctor tells you to go get allergy tested to figure out what diet to do, this will not help you. This will tend to remove unnecessary foods. It will oftentimes pick incorrect foods. And that's because this testing is valuable for food allergies where you get this immediate reaction. It's not valuable for EoE. But empiric elimination, taking away number one, the top two, top four, top eight. No, the top four: milk, soy, wheat, and egg. These are the four most common triggers. Beyond that, the nuts and the seafood. And then there are some patients that require other foods out of the diet, potentially meats, other legumes, corn, or even in some cases, rare cases, fruits and vegetables. And every patient's different. But the good news is that for the 1, 2, and 4 food diets, typically it'll be effective for about 40% of patients. And because it's effective for so many patients, it's very beneficial and useful. And again, need for a dietitian. Make sure you're not getting cross-contaminated. Make sure you're able to monitor for good weight gain, that you're replacing any micronutrients like things like calcium and vitamin D that are lost, potentially iron, folate. There's a whole slew of potential things. And really at the end of the day, for all of these therapies, it's all about shared decision making, understanding risks and benefits. With swallowed steroids, for instance, there's slight risks of developing yeast in the esophagus, or there's potentially the risk of adrenal insufficiency, and these things can all be monitored for. And all of the risks for all of these things are very, very low. These are all considered the first line of therapy. And once you have started a therapy, it's going to typically be several months, and then you're going to undergo another endoscopy. This is critical. You don't want to start a therapy, and if you feel better, just let it be. You don't want to start a therapy, feel better, and then stop it. You want to stay on that therapy, get another endoscopy done. If the endoscopy shows the therapy didn't work, you need to go on to a second line therapy, which can include the first line therapies that you didn't try and now a biologic potentially. And biologics are potentially very beneficial when there's actually narrowing present. So they're thought to be very valuable drugs when there's more of an advanced, complicated disease. And then again, monitoring long term if there is ongoing inflammation or narrowing is very valuable. So you're not going to stop your therapy. You may de-escalate to more of a maintenance approach if your doctor thinks that's reasonable. So you may drop down from twice a day to once a day. That might be something you do. But that would all be under the guise of working with your diet and then working with your doctor, and then making sure that long term your quality of life is really well maintained. Because for me, that's at the heart of it. Making sure the quality of life is good. Are you struggling with to be around friends because you're eliminating too many foods? That may be a consideration. Are you having a hard time keeping up with your medications? Are your medications giving you side effects? This is all something I need to assess. Are you gaining weight better? Are you feeling better? And this will really get to the heart of, being the best self you can be.
No, thank you for that. And I just wanted to call attention to the role of the endoscopy, especially when you're going on these different treatments, whether it's dietary or whether it's one of the prescription drug treatment options. It's important because of why. Why is it important to have these endoscopies, and what is the cadence of it? Is it every year, every 2 years?
Yeah, really important, because the endoscopy is vital because we take biopsies. And there are options for less invasive endoscopy than the being under anesthesia. So we can do endoscopy through the nose. That's called transnasal endoscopy. And this allows us to take biopsies. And ultimately, at the end of the day, getting these biopsies back allows us to understand, is there still ongoing inflammation? Where's the inflammation? Because we typically will take it from at least 2 different areas of the esophagus. That will help us understand, is the therapies that we're giving you working? Also, doing endoscopy gives us a chance to understand, has narrowing developed? Have you developed a complication? If so, this may be a problem. And then endoscopy can be valuable, of course, for saying, is there inflammation in the stomach? Is it in the small intestine? And for patients with EoE, this can potentially be an issue. Typically would be something you'd find early on, but an important part of the process. As far as how often you need it, once you go into remission, and remission means that the inflammation is much, much better, typically less than 15 eosinophils per high-powered field is sort of the magic number. But once you go into remission, the cadence for the endoscopies is really dependent on how it's really up to the doctor that's treating you, because at the end of the day, there's not clear recommendations on exactly how frequently endoscopies could be done. But the general rule of thumb for me and my own patients is that I want to understand, is there scar tissue that's developed? So do you have a narrowing? If you have a narrowing, I'm probably going to be more aggressive at going back and making sure that things are good. Do I need to stretch that narrowing out? If you don't have that, are you keeping up with your therapies? If you're not really keeping up with your therapies, again, I'm going to be more aggressive at going back in there. Are you feeling well? Are you growing? Do you have any symptoms? Are there any adaptations that have occurred? And for all these reasons, I may be more aggressive. And we're talking about something like 1 or 2 years for patients that are doing extremely well. I've assessed that there's no narrowing. They're very good at keeping up with their therapy. They're showing up to clinic every year, and I've got a good handle on how well they're keeping up with their therapy, and their quality of life is good. They're doing well. I may wait a couple of years to really go back in for a surveillance endoscopy, and I do think that's generally okay.
So there's no cure for EoE, correct?
Unfortunately not.
So when someone's in remission, would they need to keep on their medication, or does that mean it stops?
Absolutely. So we talked about this earlier. In some cases, we can slim down the therapy. We can de-escalate. So you may go to more of a maintenance type therapy. And if you're on a twice a day medication, you may be able to go to once a day. There's some folks that if they're on a therapy where they're doing it weekly, they may be able to space that out a little bit. Although, again, this is going to require more endoscopies to figure out, if I lower the dose of my therapy, am I still in remission? And so figuring out what's appropriate maintenance for some patients, I start a therapy, I'm just going to keep them on that. They don't really want to keep doing endoscopies to figure out the minimum amount of therapy. And the key, as you mentioned, you just cannot stop your therapy. Anyone that's going to stop their therapy, in almost all cases, the disease is going to come back. And at some point, you are going to get narrowing in almost all patients of the esophagus. And then food will get stuck when you're out to eat, and you'll end up in the ER.
Oh, thank you for that. And that's a great segue to my next question. As I mentioned, we talked to a mom and her son, and the son's about to go to college. And this is transition of care kind of a question, right? The college student now is on his own, or she's on her own. What does that look like for care? And, we want to keep, the goal is to keep the disease at bay, and to, if they're in remission, continue. What are your tips for that transition of care and putting the responsibility more and more on the child who's now becoming an adult?
Yeah, I think staying in contact with your physician is really important. We offer telehealth. I think telehealth is one of the most valuable things that has allowed me to stay in touch with patients. A lot of pediatric centers now are seeing their patients into their 20s. I think this is in many ways the effect of COVID. I think that's okay to be seeing your pediatric gastroenterologist who knows you well. But I do think once you're in your early 20s, it is time to transition to an adult doctor, and beginning that process when you're in your teens, understanding what's wrong with you. What do I have? What happens if I don't treat it? What's my therapy? What do I need to do to keep up with my therapy? This is all, at the end of the day, the vital thing. And remembering, you can't just put it aside and think it's just going to go away. The patients of mine that have done that, they almost all have strictures, and I need to deal with that. The patients that have kept up with their therapies, it's like a quick 10-minute visit. They're doing well. And, I'm probably doing an endoscopy every 2 to 3 years for them because they're doing so well. So I think just stay in contact with your physician. Think about, what are my next steps? Am I going to be moving to a new city? And then, going from there to really establish that care long-term with your transition.
Well, Dr. Wechsler, thank you so much for shedding light on the complexities of pediatric EoE and helping us better understand what families face in their journey to a diagnosis. For our listeners, remember, you're not alone. And with the right team and tools, there is hope and help. Visit gastrogirl.com or download the Ask Gastro Girl app to find out more information and access resources. And for an amazing resource, check out AppFed at appfed.org. Thanks for listening. Until next time, stay informed and stay empowered.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. please consult a licensed clinician in your state regarding all matters related to your health.